So hello everyone. So thank you very much for joining this TNT session sponsored by Edward Life Science entitled New Possibilities in Mitral TEER. And the session objectives are to understand how novel TEER device provide new possibilities in this field and to learn procedure step by step of this novel device, and to review the clinical evidence strategy and become acquainted with the most current data available. So I'm Kentaro Hashida from Keio University, Tokyo, Japan. And co-moderators is Dr. Diri Jichet, very famous, well-known. And we also have the discussant, Dr. Shunsuke Kubo, and Dr. Masaki Izumo, and Dr. Hies Adam. And we have the three speakers and four speakers, and Dr. Yohei Ono, Dr. Shin Shirai, and Dr. Sam Dawkins. And we also have the Dr. Ken Shizu as a speaker. So maybe Didier, could you please encourage the...
Yeah, so as usual, you are now more than familiar with the spirit of these sessions, the entire sessions that we try to develop. It's all about providing you with the maximum information. So getting your feedback. Your input during the session is of utmost importance. What you can do is to use the app, send us your questions, and we will try to address them. Or you can directly stand up and use one of the microphones that you see distributed within the room. So it's a new device, so there should be a lot of questions. Feel free to ask anything.
Perfect. Okay, so I'd like to introduce the first speaker, Dr. Kenichi Shizu from Kokura Memorial Hospital. Actually, he's quite hardworking. He only sleeps 2 hours per day. So Kenichi, please start.
Yes, thank you. Thank you for your introduction. Dr. Hayashida, I'm a short sleeper, Kenichi Shizu. I'm going to present the first Pascal case in Japan. This is my potential finance disclosure. The 79-year-old female with a history of long-term use of steroids for Craggan disease presented with NYHA class 3 DOE, which had gradually worsened over the past 6 months. TT showed severe MR due to prolapse of the P2 leaflet. So she was referred to our hospital for invasive treatment for MR, including mitral TEER. T images showed in our hospital showed normal EF with severe MR and a moderate TEER with an estimated pulmonary hypertension. Aortic valve had some degenerative changes, but the degree of AS is only mild. Subsequently performed TE showed a severe regurgitation jet with its volume of more than 100 milliliters. That mainly originated from A2P2 portion due to the P2 prolapse with ruptured cord. In detail, from the lateral side, but it was lateral side accessory trivial jet was also detected, but it was likely to be associated with indentation. 3D images showed, wide prolapse of P2 leaflet and significant MR jet flowing in a direction of the anteromedial wall of area. We also performed ECG-guided CT scan focused on mitral valve to assess localization of prolapse and subvalvular apparatus in detail. By moving, line on the left panel, the corresponding cross-sectional images can be seen in the right panel. This analysis shows the lateral portion of P2 is the main prolapse region with flared leaflet, where the medial portion has only mild prolapse at its base. With regard to PV flow pattern, quite low systolic wave as compared with the diastolic wave as identified in every PV. In particular, right upper PV flow pattern suggested the direct entry of MR jet into the PV. This slide shows that leaflet information on frayed width, gap, and PM length None of these valves presented a significant problem in performing mitral TEER. Transseptal puncture site was evaluated using 3D images. We believe that in our experience, an approach from 30 degrees anterior to the A2P2 line allows the most stress-free catheter manipulation. And based on this theory, we determined the puncture site to be mid to inferior and posterior position in the fourth cell valves. This is the last slide of my case presentation. Could you all please discuss the strategy for this DMR case? Thank you.
Thank you very much, Cage, for your very clear demonstration. So a 79 years old female and 37 kilogram, a quite frail patient. And she's on the prednisone for a long time. So she also had the PD Pro severe MR as well as the moderate TR. So maybe I will start with from the Masaki, your echocardiographer. Mm-hmm. So what do you think of this case, and what is your treatment option for this case?
Yeah, I think the echo is important for assessment of the MR and for TEER. So this patient had central pathology of the prolapse, no P2 prolapse, only P2 prolapse. And also they have no huge gap, 4.4 millimeter, and mitral valve area is also big enough. And also proximal mitral leaf length is more than 10. It is a very good candidate for TEER.
Okay, perfect. Thank you. And Shinsuke, you had a really huge experience for the mitral TEER. And which kind of device would you choose for this particular case?
So I think before the introduction of the Pascal device, so we can use only the mitral clip device. So we have to select from among the 4 clip sizes, and based on the Masaki's assessment, so both the reflect enough and the flare width wide. So I think mitral clip XCW is suitable for this kind of the anatomy. But my question is about the Pascal. So Pascal device has two devices, Pascal P10 and Pascal ACE. And this is a central pathology and wide flare. So P10 is wider than Pascal ACE. So I asked the expert of the Pascal for which devices so should be selected, the P10 or ACE.
Okay, perfect. So Dr. Heath Adams, you have huge experience with the Pascal device.
Yes.
Which type of device would you choose for this particular case?
Yeah, so we're slightly unusual in the fact that we've started a program last year for TEER exclusively with the Pascal device. And in this particular case is a really good starting point in terms of A2P2 pathology. And I think in terms of the actual device here, there's a reasonable amount of tissue. I think I would go with the ACE device. I think that certainly provides benefit with this A2P2 pathology.
Okay, perfect. Okay. Sam, what is your opinion for this case?
Well, usually if you ask 10 cardiologists, you'll get 10 opinions. But on this occasion, I'm going to agree. My sort of rationale for looking at anatomy is if there is too much tissue, I generally use ACE. If there's too little tissue, I generally use P10. And that's because P10 has a spacer, so it puts leaflets under less tension. In this case, we're wanting to try and constrain as much of the redundant tissue as possible, and therefore I think ACE would be a good choice. And the other thing to add is that the imaging we've seen so far, beautiful imaging, by the way. I mean, the CT is amazing. But with the imaging we've seen so far, I don't see any particular hazards. I don't see calcification. I don't see clefts. I don't see tethering. So I suspect you could use either device, but probably I would choose ACE in this situation.
Okay, perfect. So Didier, what is your thought? Expert.
So to make it simple, I'm a big fan of the ACE because it allows to grab more tissue, and unless you are facing a situation anatomy, we're going to develop that throughout the next 90 minutes. But if you are not commissural, if you don't have a short restricted posterior leaflet, a risk of potentially a high residual gradient, I have the feeling that it has become the device of choice. What we may discuss is the fact that we anticipate 1 or 2 Pascal for this procedure. The mechanism should be treated. So let's see. We're going to see in the case how the team handled that. But to answer your question, it would be Pascal ACE and potentially 2 devices for this patient.
Okay, you prefer the 2 Pascal ACE. Okay. So maybe this case can be treated with either the mitral clip or a Pascal device. And maybe we need to know more and more about the Pascal device. So I'd like to invite Dr. Yohei Ono to explain the overview of the novel TEER Pascal device.
Thank you, Kentaro. So I think the Kokura team will show a beautiful case demonstration of using Pascal device. But I just want to go overview of the novel TEER device, the Pascal precision system. We are all in the learning phase of this device, but I want to just shortly introduce this system. It comes with 3 catheters, actually. First, we have the guide sheath catheter, and then comes the steerable catheter, and then finally we have the implant catheter, which has actually the Pascal device. Actually, thanks to this system, there's a one-to-one response, which we can appreciate really well. And the bottom part is we can reuse it each cases. So we just appreciated the discussion whether which device is appropriate or not. It comes with 2 implants. First is Pascal ACE implant. The other is Pascal, so-called P10. So what's the difference is that, as mentioned by the expert panels, the length of this part is a little bit slightly longer in Pascal ACE. So we can achieve a more amount of tissues inside. This is a clasp that with paddles and the clasp we have the leaflet inside. How to hold the leaflets? There's a retention element shown here. It's a single row. It's quite unique, and it's less traumatic to the tissues. And this spacer is a unique feature of, I guess, the Pascal system. That preserve the natural physiology of the mitral valve opening. So as for 2 Pascal implant here, shown in the left is a Pascal ACE device. The width is 6 millimeter, and this length is 11 millimeters. If you go to the opening 180 degrees position, both devices are 26 millimeters. The right-hand side shows the Pascal implant, so-called P10. P10 because the width, including those spacers, are 10 millimeters. As said by I guess Sam mentioned that thanks to this spacer, we have less leaflet tension in this P10 system. So one of the unique feature of this device is that, as you can appreciate here in this movie, that it actually opens in diastole and closes in systole. So considering the post-procedural mitral valve opening, this has a kind of advantage. As written here, it closes the implant to conform to native anatomy and flex during the cardiac cycle. And as mentioned, this central spacer is a unique feature of this system. And actually, there's a nice experiment here without spacer and with spacer. We can appreciate that with spacer reduces stress on leaflets and 20% increase in open orifice area during diastole. And actually, we can appreciate with these schema here below that there's a significant difference. And with the spacer system, the leaflet has less stress. It means a lot of blue color part shown here. And another unique feature that I felt with this Pascal system is that it has an elongated position. And with a procedure advance, we close and get to the capture ready and clasp down and then capture, close. There's various configurations of this Pascal device. And I guess so for those of you who have attended the mitral TEER session in the first day, we have actually discussed about the commissural prolapse cases. And it could be one of the advantage to use this system in such kind of space because we have to deal with a lot of chordates and subvalvular apparatus. And this elongated position facilitates to come back to the left atrium more easily. Thank you for your attention.
So thank you very much, Yohei, for your clear explanation. If you don't mind, so please stay with us on the podium, if you don't mind. And so actually, there is some difference between the mitral clip and Pascal device. And the Pascal device has two sizes. Pascal Ace, the smaller one, and the Pascal P10 is a bigger one. And P10 has a very big spacer to decrease the risk of the creating stenosis, and it also contributes to the decrease of the mitral regurgitation. So let me explain Japanese a little bit.パスカル2個種類があって、エースっていうのがちっちゃいやつで、P10 という普通のやつが大きなやつで、大きなやつは特に大きなスペースがあるので、スペースがあることで、この逆流が減ったりとかですね、この、圧があんまり上がらないっていうような特徴がある。あと、エースが多分 XTW と似たようなサイジングというふうに考えていいみたいです。はい、ありがとうございます。And so I'd like to ask the Shinichi and to demonstrate how you treat this particular case.
Okay. So thank you very much. So I'm now introduce the Japanese first case of Pascal. So this case is already Kenichi presented that this patient is a P2 lateral prolapse. So and just like this. So our team implanted the Pascal Ace. Pascal Ace is more length, length is longer for leaflet captures. So, and with step-by-step insertion techniques. So, and at first there is no differences between the other material device. So, and the as Kenichi said, it's all the mitral in order to make septal puncture. So and the height is 38.3. So it's just planned, and we inserted this septal puncture like this. And at first, we insert the guide Cs. So compared with other Cs, so the guide Cs is extremely smooth from RA to LA. There is no stress, and like this. And then inserted the Pascal device. At first, the Pascal device was inserted by the extend positions, like this. And unfortunately, the Japanese patient is a small LA, so a little bit difficult to insert the LA and the manipulating the inside a small LA. So as you can see, the elongate position to close positions like this. We have to care about the Pascal don't pinch the Cs. Okay. Like this. And after close position, we start the steering down to the mitral valve. So, and like this, so the steering catheter handle or rotating. So, and other MTR device, so M knob with posterior is steerable guiding catheter, but there is no no need to posterior motion. So only the steerable catheter handle on rotation only, like this. And the trajectory, a check. And after steerable center, steerable catheter handle, then the clip itself moves the implant catheter handle. So it is completely different from the manipulating catheter. So, and I will check the trajectories, and then insert the LV, and opening, and opening the power, and the down the clasp here. Down the clasp. Like this. And rotating the implant catheter handles are rotate. Then close the grip. Clasp. Sorry, clasp, no grip. It's very difficult. Sometimes it get annoying me, yes. Like this. But as you can see, they do not completely insert the posterior leaflet, so because of the elongation of the posterior leaflet. And so we decide independent grasping and only posterior leaflet, and go to the grasp to the posterior portions. Okay. Like this. At the grasp. Yes. And go to posteriors. And grasp down. And close. Like this. And if we are familiar with another device, so implanting and grasping the leaflet, it is not. There is no differences between the two procedures, so we are familiar with it. And like this, the completely insertion of the posterior leaflet. And as you can see, the residual MR is trivial. And then we release a grasp. And compared with another device, so the needle is not outside, already covered by the catheter, so it is a little bit safe within the LA side, inside, just like this. And this is the final result of the implantation. This is the 3D images of the grasp. And we can check the airway pressure. So this is a pre-procedural airway pressure, but after that, extremely down the airway pressure. And there is no mitral stenosis, mean pressure gradient at 1.7, and there is no residual reverse flow at the PV. So procedure summary, we experienced the first Pascal procedure in Japan. Pascal S was implanted for P2 lateral prolapse. The independent grasping enabled good insertion of the posterior leaflet and grasping because of the length of the posterior leaflet. In final result, residual MR was achieved grade 1. LA pressure was markedly decreased, and no MS was observed. So thank you for kind attention.
So thank you very much for your very beautiful demonstration of the mitral TEER procedure with Pascal ACE device. Actually, this case is 79 years female, very fragile and frail, and she's on the pregnant for a long time. but finally you treated patient really well. So I congratulate on your team. And your echo image is also very beautiful. I congratulate on your team as well. And so I would like to ask the Shinichi, you have already done several cases. What is the major difference between the Pascal and mitral clip in terms of the manipulation or?
Yes. So the Pascal was already have a technology of Sapien 3 device, so very easily inserted the guide Cs, and also the easy to manipulate and the separate portions, such as the steering down and the clip manipulation portions, and furthermore, extremely easy to manipulate. There is no complicated sections, and furthermore, and easy to make a height. Inserting in other devices, the ANOV and the anterior posterior SCC. So, and a little bit, so sometimes the lateral portion to the catheter and the clip. So we have to more MNOV than the height is not so, we can make it. We cannot make the height, but this catheter is easy to make a height, and furthermore, inside the catheter more inside, so make a height easily. Okay. It is a very nice catheter.
Yep. And first of all, the device looks like Sapien, right?
Yeah.
And it's quite ergonomic and very intuitive to manipulate. Right. And you mean the height gaining procedure is also easy with this device. Okay, that's really a good input. So, so Didier, you also had huge experience. What is this?
So I think what the main conclusion from Shinichi experience is that this is a quite user-friendly device, and it's not a big surprise because it matches more or less the standards that we see in terms of catheter design and ergonomy with the Sapien, the Commander. Maybe we could go more into a more technical discussion, because I think that the audience here needs to get more information about that. Maybe let me just ask you, raise your hand, those who have experience with Pascal. Raise your hand, please. So we need to have that discussion. What it is, I think it's very important to come back. Yoe, would you accept to go back to the podium and show your slide with the various elements of the catheter, and then we can clearly guide you through the way it's manipulated and what it's going to achieve in terms of action within the atrium. So the first step, as you've mentioned, Shinichi, is the transseptal puncture. So I'm going to turn towards my left. And usually for mitral TEER, what we aim at is a puncture around 4. Is it the same thing? It's 4 and posterior, superior and posterior. What is, Sam? What is similar and what differentiates the Pascal, the entry site, from the other device?
So, as with any TEER procedure, getting the transseptal in the right place can make a huge difference to how straightforward the procedure is. You can make a procedure very difficult if the transseptal is in the wrong place, and that's also the point. It is really the only point, really, of the procedure where it comes down to safety. You need to make sure you're in the right position, both for safety, but also because of ease of steering. So what we're looking to achieve is in the superior-inferior view, we want to be mid. And in the AP view, we want to be posterior. If you're mid in the superior-inferior view, you're less likely to aorta hug. And if you're posterior in the AP view, again, you're less likely to aorta hug, but also you'll get enough height. So to gain height above the mitral valve, you need more posterior, not more superior. For Pascal, I think because the height gaining and height losing maneuvers are very they're very pure movements and they work very well. It's quite forgiving. So particularly if you're looking after a patient with a small left atrium, you can generally navigate that by using advanced steering. But it's much better not to have to do that. It's much better to have a transseptal in the right place so you don't have to use advanced steering. It makes the procedure much more straightforward. So what you need to aim for is about 4.5 centimeters it's not, I suppose with mitral clip, it probably you think the more the better, I suppose. Whereas with Pascal, I think if you're too high, you get more movement of the device over the valve as you cross if you're a long way away from the valve. So I would advocate not going beyond about 5, ideally about 4.5 centimeters. So those would be my thoughts on Transseptal for this device.
So thank you very much for this clear description of the perfect entry site, puncture location. There is also that new concept of being on top of the medial commissure of the mitral annulus, just to make sure that when we're going to steer extremely parallel to the valve and perpendicularly go downwards. That if we move after getting access to the septum, the second part is to make sure that we are going to steer the guide sheath in a parallel position in comparison to the mitral annulus. That's something that is quite new, so these are very important steps that we need to achieve at the very beginning, to make sure that every time we placate the guide sheath, it's not going to go up, the tip is not going to go up or down. So it's all about the rotation. If you watch the guide sheath on the slide, the most proximal aspect of the delivery system, it's all about finding the degree of rotation that is going to achieve that parallel movement. The flexion is going to bring everything parallel in comparison to the mitral valve. And this is a very important step. And as Keith has mentioned, you don't want to get into these gaining height, losing height maneuvers that are going to increase the complexity of the procedure. So Keith, in terms of overall orientation of the guide sheath, what would you recommend for the audience when they will start their experience?
Yeah, so when you're starting the experience with the Pascal system, it's very important to do your practice maneuvers before the case. There is the beating heart model which can assist in this, but in terms of the orientation, the guide sheath, you generally want to have the flush port, which is located just adjacent. You can see within the guide sheath handle at 4 o'clock. You then want to have the steerable catheter handle. There's a fin there, which you generally want at the 2 o'clock position. And then the implant catheter handle, you want to have at a neutral 12 o'clock position. So if you ever forget, it's 4, 2, and 12, distal to proximal to the operator. And from that perspective, you'll be able to manipulate quite easily within the left atrium.
So that's very clear. Yeah, so I guess you wanted to add something?
Yes, but it's just to mention that a really important point, which we often don't say, but I think is worth mentioning, is the fundamental difference between this device versus the mitral clip device when it comes to the subject we're talking about now, is that it's not keyed. So the mitral clip device is keyed. You cannot rotate the two guides against each other. The Pascal device is not keyed, and what that means is you can have the steerable and the guide in any orientation related to each other. And that means you can steer in any plane and handle any steering difficulties. So by altering where the guide port is, which is usually 4 or 5 o'clock, you can gain height, lose height, fix aorta hugging, fix reverse aorta hugging. So you can do any of those things, and that is because it's not keyed.
Very important points. So if we go back now to the general management of the patient, most of the time we need to provide heparin to the patient. It's mandatory. Your way, do you have the same target in terms of achieving an ACT? Usually we say above 250, close to 300. Is it the same thing, or do you?
Especially we deal with the left atrium. I aim above 300.
Above 300.
And on top of that, I give heparin before the transseptal puncture. Because as soon as we enter the left atrium, potentially thrombus formation could happen with no heparin. So I tend to give 3,000 units of heparin first, and then according to the ACT, we will add some more later.
Okay. So as we are still in it's normal that because as it is new, there is a tendency to try to compare and understand the differences in between devices. So one of the very first steps is to get access to the femoral vein. So have you, based on your experience, now more on my right side, based on your experience, do you still go for a percutaneous access of the vein, or are you moving for, as it is the case for some TTVR devices or TMVR devices, for a surgical exposure of the vein. Shinichi? No, and then
Oh, yes. So all of the procedures are done with the ProGlide. ProGlide, no surgical cut down.
one or two ProGlides are you using?
One ProGlide.
One ProGlide.
Yes.
And it seals?
Yeah.
Okay. So this may be a slight difference because usually we use 2 ProGlides for a TEER, mitral TEER procedure. And it's good to see that with one we may still achieve hemostasis.
Yes.
There is something that is quite important during the procedure is the assessment of the result, and this is more an echo thing, assessing the result. Do we explore the same parameters based on your experience as compared to what we are used to do? Because the experience with the other device is so huge that we are doing things without even thinking about them. Do we assess the things exactly the same way? And could you describe them?
Yeah. So result assessment is very important. So leaflet insertion assessment and residual MR is also important. So if in our experience, so leaflet insertion assessment is the same for both devices, but it is not easy to grade the residual MR. And this case was color Doppler is also residual MR is related trivial. And left atrial pressure is going down, and pulmonary vein flow is SOF dominant, it is compatible, all of the measurement. Mm-hmm. I think it's sometimes difficult to judge the discordant these parameters, but not only echo parameters, but also atrial pressure and any other parameter is also needed.
I have one question.
Sure.
Actually, this case that she chose ACE for it, and the team actually really great result. I mean, my question: they could have done Pascal with P10 device or not? Maybe Didier. So could you please answer this question?
Yeah. I think this is also a good case, very good case for a P10. So it's Pascal with a wider spacer. I tend not to use it anymore because as the ACE is available, this has become my default strategy. But from time to time, and we may discuss that afterwards, a P10 works. So in this case, I think one could expect exactly the same result with a P10. Mm-hmm. The thing that we could discuss is the fact to add a second Pascal, at least to mainly to secure the mechanism, to secure the immediate result and to avoid any recurrence. So maybe Shunsuke, if you want to answer that, based on your experience for mitral TEER in general, for this type of prolapse, do you advocate to only, because we know that with these devices we can achieve no regurgitation or mile or trace, so it's not the point. It's more about making sure that there is no recurrence of the regurg. So what is your strategy now?
So the TEER procedure is approved in Japan I think that 6 years ago. So there is an experience for the 6 years. We experienced some MR recurrence due to the residual prolapse. So there is only a trivial MR, the mild MR, but if we can see the residual prolapse, it can be a risk of the recurrence MR. So that's why now my clinical practice is changing. So if the previously we left the residual prolapse with a small jet, but now we have to cover all parts of the prolapse, so as much as possible.
So that's a very important and contemporary comment. That is to say that we should really tackle the disease and the mechanism. So Shinichi, you will have to tell us in a couple of years about the outcome of the patient, if there was any recurrence or not. Yeah. In the future, you will let us know.
Yeah. In the future, I will report.
So let's say, based on the literature, maybe Keith, we say that on average, we're going to see that in the data, it's like 1.4 or 1.6 device per patient for the most regular anatomies. Have you seen an increase or a change in the gradient Because with what we see usually with the over device is that when you put a second device, you may increase, or often you change the gradient. Have you seen that with the Pascal based on your experience?
No. So what we've noted is often the gradient will stay the same or actually even improve when you deliver the device, and that whether it be one or a second implant. And certainly when we have put in a second implant, we have found that the gradient actually drops once we release the device. So furthermore, the MR reduction that you're left with prior to release sometimes gets better, or often gets better as well, and that's certainly accompanied with the other adjunctive features that we look for. What we didn't emphasise before on the steerable catheter handle is you can easily connect your LA pressure monitoring. It is certainly useful to have systemic pressure, whether it be from an arterial trace, and you will see a substantial reduction in the LA pressure and often an increase, particularly in the degenerative patients, of around sort of 15 to 20 millimetres of mercury on the mean arterial pressure trace when you do close the device.
So it's true that monitoring that pressure is could be part of the assessment. You said that during our learning session.
That's right. Yeah.
And it was the very first device with that feature. Mm-hmm. Another feature that was initially provided by the Pascal is that independent capture of the leaflets. So Sam, is this something that you use quite frequently, that independent capture, or is it just a feature that is available but that is useless?
Actually, I use it pretty much all the time, and there are two reasons. One is you can, if you're grasping independently, you can steer towards the leaflet you're grasping and optimize as you close. So that's one reason. The second reason, which I think is actually almost more important, is you can focus your imaging on the leaflet you're closing. So you can really focus to understand exactly how much leaflet you have. You want to see the leaflet going right into the apex as you close, and you want to close really slowly so that you really understand how much leaflet you've got. The only time when I use simultaneous grasping is where it's a valve that's really tethered and under tension, in which case independent grasping may well introduce more tension and can make the result a bit more difficult to get to. So if it's a very flat valve with the leaf that's very under tension, then that might be the occasion when I do simultaneous grasping.
Okay, so we have time for one question. It's for you, Yoe, because you nicely drove us through the features of the Pascal. We've seen the catheter. I hope now that you better understand how it works and how you set everything to get the proper trajectory. Sorry. We've discussed, Yoe, about the gradients that remain stable. Let's say it's stable. Mm-hmm. From time to time decrease, even if you put 2 Pascal. Do you think that it has something to do with that, the structure of the device?
I think so. This device is made of nitinol, and it has the coating. So this nitinol is a very flexible material. So as we saw through the small movie, while during the cardiac cycle, systole and diastole, this device, Pascal, obviously with Pascal and Pascal Ace, actually slightly opens in the diastolic, and we can appreciate that also in the fluoro. So I think this is a kind of a difference that we appreciate in this new system.
Thank you very much.
Okay, yep. So one question to Sam. Actually, we Asian patients have a lot of patients with a very small mitral valve area. And with MitraClip, we tried to choose the smaller one, NT or NTW, when there is the very small mitral valve area. For Pascal, Pascal P10 has the spacer, which may lead to the decrease in terms of pressure gradient. On the other hand, the Pascal Ace is smaller than P10. So which device would you choose for the patient with small mitral valve area?
Yes, so that's always a tricky one. And I think the mitral valve area, it really is not a perfect correlation to whether that patient will have mitral stenosis if you put in an edge-to-edge repair device. That's the first thing. So, I mean, this week in my center, we treated a patient with a valve area at baseline of 2.7, I think, and had absolutely no trouble with mitral stenosis afterwards. So don't get too worried about it, and you can try and see what you achieve. Mostly, in that anatomy, we would use an ACE, but it is worth saying that the P10, because of the spacer, you end up with a larger orifice area. And I definitely have a couple of patients where we put in an ACE and the gradient's been a little bit too high, and we switched it for a P10 and got a good gradient.
Okay, thank you so much.
So let me just test you again, ask you something. Do you understand now a little bit more about Pascal? Raise your hand, please. This is cool. Okay, so let's move forward. So let's go more into data now. With Sam that is going to drive us through the advancing valve repair, latest on RCT and registry data.
Thank you very much. So I'd just like to talk through some of the data that's been published so far in this field. And I'm going to look at three different pieces of published data. One is the Class 2D randomized trial, one is the Class 2D registry, and the other is the MyClass post-market clinical study. So the Class 2D randomized trial, so this was designed to evaluate the safety and efficacy of the Pascal device versus MitraClip, and it was 300 patients randomized 2-to-1 Pascal to MitraClip. And the endpoints were, as you would expect, it was non-inferiority of safety and efficacy as measured by reduction in mitral regurgitation. Quite an important part of this, and I'm going to tell you about this in a minute, is the arm that went into the 2D registry. So of the patients who were screened, there was a proportion of them that fell outside the IFU for MitraClip and therefore couldn't be randomized. And those patients went into the registry. So those were patients with more complex anatomy. Starting with those in the trial, those patients who could be randomized, the population is as you would expect, so they're patients in their 80s predominantly, high number of patients with atrial fibrillation, other comorbidities, good left ventricular function on the whole, and generally large mitral valves. So to look at the procedural outcomes, so just under 300 patients, as I said, 2-to-1 randomization, very high successful implant rate. One thing to draw your attention to is the number of Pascal devices used. This study was published and enrolled before, or at least enrollment started before ACE was available. So that's why you see perhaps more Pascal devices, P10 devices used than you might expect. There was a small difference in procedure time, not a great surprise given that Pascal was a new device at the time. Looking at major adverse events, very, very low event rates in both arms. You can see that in the Pascal group, cardiovascular mortality less than 1%, stroke less than 1%, MI 0, and those numbers are extended out to 1 year. So both in safety, Pascal proved non-inferiority to the existing MitraClip device. Looking at MR reduction, I'll draw your attention to the box in green. So you can see that the number of patients with 1+ or less MR in the Pascal group was 77% out to 1 year, compared with 71.3% in the control group, and that confirmed that we had non-inferiority in terms of efficacy. Functional and quality of life, as cardiologists, we're most interested in residual MR, but the patient is not. The patient is most interested in their quality of life. So what you can see is a statistically significant difference between baseline and 1 year in terms of both NYHA functional class and KCCQ, and again, non-inferiority from the efficacy standpoint. So Class 2D trial is important to as the proof of concept, to evaluate this device in its early phase. But the registry, to me, is the more interesting data, because this is what we see in the real world. These are patients who have complex anatomy. So if you look at the pie chart, you can see multi-segment disease, small valves, large flail widths, calcification, etc. It's much more complex pathology, and 15% of patients had 2 or more of these criteria. So this is actually what we see in the real world. So I'm interested in this data as to how it impacts on what we can do. So you can see that there was a high successful implant rate. The mean number of devices implanted a little bit higher than with the trial, as you might expect, and a predictably comorbid group of patients. And if you look at the MR reduction outcome, you can see 62% of patients had 1+ or less mitral regurgitation, and 93% had 2+ or less. So really, really impressive reductions in mitral regurgitation out to 1 year. And at least out to 1 year, these results look durable. In fact, with the number of patients at 1+ or less MR gradually increasing as time goes on. So now looking at MyClass, this is a post-market clinical study looking at the Pascal device in its early clinical use. So this is real-world data, a registry run by Philip Lurtz. So this was looking at safety and efficacy once again, looking at major adverse events for safety and change in MR severity in terms of efficacy. And this was carried out across Europe, 544 patients, slightly younger group of patients, but still high surgical risk, high successful implant rate, and you can see mean number of devices pretty similar, 1.4, procedure time similar, and very short length of stays. The length of stay longer here, which perhaps reflects some of the reimbursement in Europe around length of stay. Looking at the event rates, again, very, very low, out to 1 year. The all-cause mortality, 1% at 30 days. SLDA, single leaflet device attachment, 1.5%, which is very, very low for a mitral TEER procedure, particularly in a relatively new device. Heart failure hospitalizations out to 1 year, very low, and good reductions in mitral regurgitation, much higher than in the trial and the registry. So 82% of patients down to 1+ or less mitral regurgitation. Very low freedom from heart failure hospitalization, just about 90% out to 1 year, and improvement in NYHA class for this group of patients. And the difference with my class, of course, is it's not just DMR, it's DMR and FMR, but this just shows the NYHA class for the DMR patients. So putting that all together then, Class 2D randomized trial was a randomized trial against MitraClip, and 77% of patients ended up with 1+ or less mitral regurgitation at 1 year with significant symptomatic improvements. The registry was looking at those patients with much more complex anatomy, again with very good reductions in mitral regurgitation out to 1 year. And my clasp is the real-world data, the post-market clinical data from a European registry showing a very high number of patients with very little residual mitral regurgitation and low rehospitalization after the procedure. Thank you very much.
Okay. Thank you very much, Sam, for your very clear demonstration. So I have one question to Shinsuke. Actually, you have huge experience for the mitral TEER for the patient with DMR, and you're also in charge of our Ocean Mitral Registry, and you published our initial data using the MitraClip. And comparing our data, what do you think of the previous data for the Class 2D study and Class 2 registry and my class, and which kind of the result with Pascal do you expect in a cohort?
Yeah. Thank you, Kentaro. So I think that from our Ocean Mitral Registry, the regular MR is less than, more than moderate, is a significant predictor of the event, so mortality and heart failure hospitalization. So we have to, as much as possible, to reduce the MR in the primary MR. And also, in our findings, so after the mitral TEER using the other device, so the proportion of the moderate or severe MR is a little bit increased during the follow-up. But in the Pascal data, so some show the data, and the proportion of the moderate or severe MR is almost the same through the follow-up. So I think it's a very good point and for us, and I'm not sure the exact reason of these findings, but potentially the spacer is a reason of the not to increase the MR grade through the follow-up. Okay. How about do you think some the reason of the sustained MR reduction during the follow-up with the Pascal device?
Yeah, I think it comes back to Didier's point earlier on. It's if you've treated all the pathology, you're likely to get a durable result. I think secondly, if you've had a good acute result, you will get remodeling. You know, everything will shrink and you will end up with a better result in the end. And I think we see that in DMR, we see it even more with FMR, that if you look 1 month, 6 months, 12 months, your post-procedural result has improved generally.
So Heath.
Yep. Thanks, Sam, for a great talk. I think it's important to emphasize that in the randomized control trial, the enrollment at each site was actually quite low. I think it was less than 2 patients per year. So it's very important, and that's because of the strict inclusion criteria. So I think the results from the registry are really, really important, because in reality, our heart teams, particularly in Australia, are not served up fairly straightforward cases all the time. There's certainly surgical knockbacks with complex pathology. And I think this data allows us the confidence to treat these patients with Pascal.
Thank you so much. Actually, I'm very much surprised to see that the 50% of the cohort was treated with P10 device. And is that your daily practice, or do you prefer more and more ACE device?
Certainly we have used predominantly ACE. Certainly the ACE is well, I think we're getting to it in the session, but certainly for bicombusture pathology, the ACE is far more beneficial. You have the ability to elongate in order to stay away from the chordae and subvalvular structures. So certainly in our experience, it's been enormously helpful.
Okay. We really need to know more and more about the difference between two devices and how this difference might impact the clinical outcome, especially in our Asian cohort.
So the main conclusion from my side from the CLASP 2D trial is that these are selected patients because it's a randomized trial, but in patients with a suitable anatomy, we have equipoise between mitral clip established and Pascal. That's what we say. We can say so. And it means that for the very vast majority of our patients, we could use either device. So maybe the most important, rather than trying to oppose the devices, is to understand overall who is a suitable candidate for TEER in order to achieve such exceptional results as we've seen in the trial. So Masaki, if you had to summarize for those who are a little bit less familiar with TEER, what would be, from echo standpoint, a suitable candidate? Those green and yellow.
Yeah, it's a very difficult question. It's a difficult answer. So I think I'm really surprised about the result of Class 2D randomized trial, because even in the number of device is small in the in Pascal as compared to the other devices. The Dr. Kubo said that MR reduction through 1 year is very nice. Over the 90% is mild. So Japanese patient has small anatomy of the mitral valve and mitral valve area. The small number of devices is a really good option for this kind of patients, I think.
Yeah, that's true.
And if you have to give an advice, would it be to start with these A2P2?
Yeah, green line is the central pathology, and the leaflet length is good enough. And also, I think it's also important that transseptal height is very important to get good results.
Yeah, so I strongly support that philosophy of starting with the less complex cases, just to get experience, to get used to the device, to make sure that we can achieve an exceptional result immediately, because we know that this is going to promote reoccurrence of the device, of the regurgitation, and this is not going to be helpful for the patient. So I think at the very beginning, I guess that was the case. Maybe Yohei, in your experience, did you start with the most simple ones, or did you immediately tackle more challenging ones based on your past experience with the...
we just started the program, so only limited to P2 prolapse. But maybe we could challenge a little bit of non-central pathology while we have proctor phase.
Okay.
So this is exactly what happens if whenever we go proctoring, people bring the worst cases.
The same story as Tavi.
It is better, I think. I mean, there are two different groups here. There are centers who haven't done any edge-to-edge repair before and who are starting a program. And the challenge then is that the cases that you're referred are, by definition, quite often quite complicated, and it's quite difficult to find nice A2, P2 pathology, but it will make your early learning of the procedure much, much more pleasant and relaxing if you can get to more straightforward cases to treat. And then the centers who are experienced and are transitioning to the new device, I would recommend that you start with some more straightforward cases, just because it makes your learning curve much quicker. What people have done is taken the very worst cases to try with the new device, which is just quite hard work. So pick some straightforward ones for your early cases, and you'll find that your learning curve is actually extremely quick, and then you can move into the more complex anatomy.
Exactly. So we always need to start from the easier one, and then move to the complex one. So this device has a really nice feature of the elongation of the device. So Sam, do you think that this feature might impact your treatment strategy for non-central lesion?
Yeah, so if I think back through my TEER cases that I've done, I think probably my most uncomfortable experiences have been when I'm stuck under the valve. You know, it's a horrible experience when you're seeing that the device isn't moving freely and you're struggling to get out. That is not a nice experience to go through, and elongation means that you don't really have to encounter that. And so, what it means is that I can cross into the left ventricle through pretty complex anatomy, calcification, small valves, right into the commissure. And I know that I can try various positions, but if I can't get a nice result or I'm seeing interaction with cords, I can just elongate and get out. And that's it's a feature that allows me to take on more complex anatomy because I know that I'll be able to get out.
That's true. Thank you.
Yeah, and something that is very reassuring is the location of the retention elements that are most of the time in the atrial side. So, Shinichi, you are starting your experience in terms of procedural time, even if it was the beginning. Have you seen an extremely increase in the procedural time, or does it remain more or less the same for you?
Yeah, for me, so it is almost same compared with other devices. Suddenly, we experienced the 3 cases of Pascal. And the 3rd case is a failure of the mitral clip because of the radiation, post-radiation femoral, and 24 cyst insertion then inside the Pascal device. And the Pascal device need no posterior motion. So only steering down the P3 device, P3 insertion. It's very fine, great result. Yeah, so maybe I think it a little bit take a time.
Okay, so overall, people should not be afraid of an increased procedural time because for the most regular cases, it's the same.
Yeah, it's almost within 1 hour.
Okay.
Procedures, yeah.
Very good. Okay, so we invite Sam again to talk about the challenging cases by a novel device.
Great, thank you very much. So I just wanted to present a selection of cases that we've encountered over the last couple of years. We're about 250 cases in with the Pascal device, and I think we've handled quite a range of anatomy now, and we know what we can take on. I wanted to start with some straightforward anatomy. So this is a patient we treated last month. So nice focal P2 prolapse, flow reversal in the pulmonary veins. There are no obvious hazards here, so there's no clefts, no calcification, leaflet's nice and long, the flail gap is manageable. What do I need from a TEER device to treat this patient? The answer is I need to know that I can do a good job. I should be able to get an excellent result here. I should be able to get mild or less mitral regurgitation. I should be able to compete with the surgeons in terms of what we can offer. And so how can I deliver that? Well, I think the first thing is I need to have a device that I can deliver accurately. So I want to treat, as we were talking about earlier, I need to treat all the pathology. I need to be able to steer the devices so that they're very close to each other so that I get a good gradient, but they need to be in exactly the right position to treat all the pathology. So accuracy is important. The next thing, which is particularly important with this kind of anatomy, which is at the more straightforward end of the spectrum, is predictability. I don't want any surprises. I don't want to release the device and then see a new jet that wasn't there before. And so the top left-hand image there is before the release with a mean gradient of 3, mild residual mitral regurgitation. The top right image is after release, and you can see that the MR, if anything, is a little bit less than it was before, systolic dominant pulmonary vein flow and a nice tissue bridge. So I need to be able to have certainty that I can offer a patient with this kind of pathology, this kind of result. So that's straightforward anatomy. What about if the anatomy is more difficult? Sorry, everything is lagging slightly. My apologies. There we go. So that's the post-procedure echo for that patient. And so when the procedure is more difficult, it's helpful to have the range of devices to treat that pathology. And we've talked a little bit about the two models that we have, the ACE and the P10. And we've talked a little bit about why you might use one over another. And this is some data that was put together by a EuroPCR working group on this. So Pascal, P10 means the same thing. So the P10 device we tend to use in patients who have a restricted or shorter leaflets. Pascal ACE, we're particularly keen on using in commissural pathology. That's because it's narrower, it's less likely to interact with cords, obviously with dense caudal apparatus. And where there are longer leaflets, the Pascal ACE will constrain them more and treat the residual diseases most effectively. Now, where you need consensus, I'm going to give you my view on each of these things, but I think there's a bit of variability between different operators as to how we handle these things. So calcification near the grasping zone, personally, I mostly use ACE because it's a smaller, narrower device, and you can steer past the calcium. You can get into the spot where the leaflet tissue is healthy. Large flail gaps, I know some people use P10 in that situation. I personally use ACE because it's going to cinch the redundant tissue in more securely, I think. On some occasions with really huge flail gaps, we've grabbed the flail in the left atrium and come down into the ventricle with that leaflet attached and then grasp the other one in the ventricle. So you can do that. Small valves really depends on the pathology. You can use ACE or P10, but don't forget about P10. Although it's a big device, it often has a better gradient. Severe tethering, that can be tricky with both devices. Usually, if you can, Pascal is a better option. And then clefts. Well, clefts are a difficult one because sometimes clefts are a problem with 3D gain rather than being real. But clefts you kind of know once you start to interact with the valve. So knowing that, let's think about more complex anatomy. So we've talked about the registry. So here's a case who was referred to me. And so why would I think this is challenging? Well, a couple of things jump out. You can see there's a posterior calcific shelf. So this is a patient with severe posterior mitral annular calcification. The 3D view tells you that the mitral valve is also small. So there are two issues there. And if you look at the angiogram, you can actually see a cast of the calcification around the whole of the posterior and medial and lateral mitral annulus. There's a huge amount of calcium there. And the challenge with this kind of anatomy is that I want to be able to grasp in different places to see if I can find the best result. But I also want to be able to get out. And that calcium is definitely something you could get stuck on. And so you can see in the left there are the three different positions of the Pascal device: closed, capture ready, and elongated. And by having the ability to elongate, I can cross the valve into some pretty hazardous subvalvular anatomy, try something, and if I don't like it, I can move it, I can change the orientation, I can change the trajectory, but importantly, I can get out. And that is an important feature to consider with this kind of anatomy. And I just wanted to show you a few clips of this procedure. So this is after we put in one device, and we're now putting in the second. And having steered through the valve, I'm finding that the device isn't moving freely. It's interacting with the other device and with the calcification. And so I elongate. You can see the clasps, the retention elements are already above the valve. And then you can very safely come back up above the valve. You can reset. You can change something. So change your trajectory, change your orientation, and then recross and get another grasp. The other thing I just wanted to mention is how precise and nuanced you can be about your grasping. So what I did to get past this calcific shelf was actually close the Pascal device, come past it, and then open it and kind of lift the leaflet up as I came past. And it's very nice to have the precision to be able to do that. And so here you can see the posterior leaflet resting very nicely and getting a good grasp and ultimately a good result in what is some pretty challenging pathology. What I need to know is that taking this on, I can elongate and get out, and also I can have multiple grafts without doing damage, and I think those things are important to me. Just to spend a moment on commissural pathology, so here's a case from not so long ago. So this is medial commissural flail, and you can see the pathology in the 3D view. And the problem here is there are a couple of problems. One is a lot of cords in that territory. Imaging is more difficult, so in most procedures we use a BICOM and LVOT view to grasp. In the commissure, sometimes those views don't work, so you quite often have to use a single view. Transseptal height can be an issue, and I just wanted to mention that here. So the annulus cants away from the septum. So that means you need more height to do medial pathology than you do lateral pathology in your transseptal. And that can be a real issue. So this kind of pathology, you need as much transseptal height as you can get. And so here is our first kind of attempt. So left-hand view is superior inferior, middle view is AP, and you can see a 4-chamber view on the right, just measuring the height. So 3.89, we'd probably be able to do the procedure with that, but it's making life unnecessarily difficult because you're probably going to have to do some height gaining there. And if you're on the medial side, it can be quite difficult to keep the guide engaged with the septum, and therefore height gaining doesn't work unless the guide is actually engaged with the septum. So we managed to squeeze out another couple of millimeters to get a little bit more height, up to 4.2, and then did the transseptal with that. I thought it might be worth just pausing just to go through again, slightly more slowly, exactly how the interaction between the guide and the steerable works. So I'll show you the image in a second. Didier mentioned it. One of the things that's very different about the Pascal device is that after you've crossed the septum, you get a septal en face view where you have the mitral valve at the bottom of the screen and the guide pointing at you, and you put the guide port so that when you flex the guide, it's completely parallel to the mitral valve. And that means if you put guide flex on, you get a very pure AP trajectory correction. And that's what's showing here. Okay, so that's what you want for most patients. It means if you put guide flex on, it corrects AP trajectory, but nothing else. If you're short of height, if you clock the whole thing, so say your guide port is usually at 4 or 5 o'clock, if you clock it to 6 or 7 o'clock, it means that when you put guide flex on, you will gain height like that. You will also correct aorta hugging, but you will gain height. And so that is how you gain height, and it's a pretty pure movement, so you tend not to get other unintended consequence from using it. It's not that common that you have to lose height, but if you do need to, you just go the other way. So you anti-clock the guide, move the port more towards 3 o'clock, and then when you put guide flex on, you will lose height. So by moving where the port is, you can steer in any plane. And so here we're doing our transseptal. Height actually is just about okay. And this is the view I was talking about. So this is the septal and fast view. Mitral valve is at the bottom of the screen. Guide is pointing towards us. And you can see as I roll the guide flex, the guide is flexing parallel to the mitral valve. So that's what I want at this point. And so now we're steering down towards the valve. I'm under the valve. I'm having an attempt at a grasp. I don't really like it, so I'm going to elongate, come back up into the left atrium, and I think the problem here is that I'm aorta hugging. If you look at the right-hand view there, you can see that we're aorta hugging, and the way to fix that is to put guide flex on, and I thought I would gain a bit of height as well, just to make my life a bit easier. So we're doing this maneuver, and you can see the change. It's really powerful movement, and it's very precise, and it translates very easily. So we're now much more vertical, less aorta hugging, and we've also gained a little bit of height. So now we're just crossing through the valve, going under the valve, and just grasping. Here I'm grasping independently, anterior first and then posterior, and ending up with a very nice result. Very little residual mitral regurgitation, and a good gradient, and normal pulmonary vein flow. And so we've left this patient with a single orifice valve and no significant residual mitral regurgitation. So I hope that's illustrated some of the features of the Pascal device. It is safe, accurate, and predictable. The Pascal design features give me the confidence to take on complex pathology. So elongating allows me to safely get out of trouble. I can get back to the left atrium very easily. And the height gaining and losing maneuvers are very responsible and can make challenging pathology more straightforward to treat. Thank you very much.
Thank you very much, Tom, for your very nice explanation of this novel TEER device. And actually, I'm very much impressed to see your cases that it's quite maybe easier or suitable to negotiate with the medial lesion with this novel device. And gaining height procedure could also very much powerful to go more and more high, much higher. So which kind of the patient do you treat, preferably with the Pascal device for DMR?
So I think, I mean, most pathology you can treat with both devices, but there are certain types of pathology that would lean towards Pascal, I think, and it's patients where you're concerned about getting stuck, entanglement, so patients who have posterior mitral annular calcification, patients with annuloplasty rings, for example, and then positions on the valve, so particularly commissural pathology, I think would lean towards, I would certainly lean towards Pascal in that situation.
And you also commented on the if the patient had the shorter leaflet, you would choose the P10. And if the patient had the longer leaflet, you would choose ACE. Could you please explain more deeply?
Yeah, so perhaps the better way to explain it is not so much in terms of leaflet length, but it's in terms of redundant tissue. So if there is a load of excess tissue, what you want to do is actually cinch that all together and put the valve, the leaflets under a little bit more tension. So that's your classic DMR pathology. So, big exuberant P2 prolapse with flail. You actually want to constrain the tissue, in which case ACE might be a better option. Where the valve is very flat, so say the patient's had atrial fibrillation for the last 30 years and the valve is like that. So it may not be that the leaflets are short, but they're certainly restricted and they're under tension. In that case, you might prefer to use the P10 because the trouble with those kind of cases is that if you put the leaflets under too much tension, you can end up chasing the jet along the valve. You put one device in and chase the jet down. Whereas with P10, you tend not to do that because you're not putting the leaflets under tension.
Actually, in our center, we have done only one case, but it's a mixed etiology with DMR and FMR, atrial FMR as well. And the leaflet was so flat, and we chose P10, and jet was quite wide. But finally, we achieved really nice results. So P10 could also be chosen for the patient with this kind of very complex lesions.
There is a question that brings us back to the learning curve, and it comes from the audience. It's more about, so it means that there is interest in acquiring more knowledge and skill at using the device. So the question relates to the number of cases that is required to become really comfortable with handling the delivery system, steering towards the mitral valve, and any specific advice just to shorten that learning curve, Keith?
Yeah, I mean, I did mention before it's nice to do some ex vivo work. The beating heart model the Edwards team does have, and I suspect it will be available to most countries here. Furthermore, I think the learning curve is not just the proceduralist. I know there's a lot of proceduralists in this room, but to do these procedures, you really need to have good synergism with your TOE operator and your imaging cardiologist, and you need to work together with these cases. It's also very important to pre-plan, as opposed to the device itself. You need to pre-plan what your strategy is, whether it be degenerative or a functional case. But in terms of the actual procedural number, we've found that the ease of use of the delivery system, the stability rail, the three components really, as Sam has mentioned, allows for very precise movements. And these cases are exceedingly relaxed. There's no rush in terms of, we mentioned before, time. I mean, the majority of our initial cases took around an hour, and certainly the results are really quite excellent. But I would say to you that at least 10 cases would allow for reasonable proficiency, and in Australia we need to be proctored for our first 10 anyway.
So 10 cases, same advice, more or less some?
I think so. I think the best way, I think the number of cases is important, the cadence is also important, so it's certainly for proctors, what we like to see is people doing 2 or 3 cases and then doing that at least monthly, if not more, because then you make progress quickly. You're not taking 2 steps back every time. If you do 1 case here and then 1 case in 3 months, it takes a very long time to get proficient. And so the best thing to do is to commit to it and say, we're going to do these 10 cases in this amount of time, and then you'll make progress really quickly. And it's worth saying that, case 1 and 2, it does feel different. It just does. It is different, but it doesn't take long for you to get beyond that point and for it to feel very natural.
So these are very good advices. I guess that, so we heard that 10 cases could be a good number, but it's more about getting familiar with the device, so it goes through in-house cases, as well as attending meetings as you guys are doing, and combining it potentially with workshops, trying to get more familiar, seeing more and more cases. Because overall the philosophy of treating mitral regurgitation with a TEER device remains the same. It's more about trying to understand how it is when you use the device, the Pascal within the patient. I had one issue that I would like to address, because we've seen a perfect world. Everything goes smoothly, one device, and everything is fine. But from time to time, you get entangled within the chordae. So any tip, tricks, or specific maneuver that you do to get to handle that situation? Because this is something that we need to know. It's not going to be frequent, but it may occur. Who would like to jump in first?
I mean, it is uncomfortable when that happens, but the more complex anatomy, it will happen. And the trick to doing it is to firstly undo what you just did. So whatever you did, take that off. And then you just have to keep trying things. So most of the time, if you elongate, you'll be able to get out and it'll be fine. But occasionally you can't. And if that's the case, what I would recommend is elongate, and then you can try just moving in the different planes. And the trick is that if you put a movement on and it doesn't help, take it off. Because what you don't want to do is do 10 different things, then you end up with very odd bends on the guide, and it makes your life very difficult. So what I would do is elongate and do a fairly big posterior torque, fairly big anterior torque, and just see if that frees everything up. But taking it off each step after you've done it. And then sometimes what works, if that doesn't work, is you can gently unflex the steerable, and sometimes it'll come out the lateral side. But if that doesn't work, put the flex back on the steerable so that you're not having the valve under a lot of tension. And just do all these small movements and keep doing them. And just when you think you're never going to get out, you will get out. And that's the way to do it.
Thank you. This was very, very clear. So the title of the session is, in fact, a new device for TEER. It's not only about the mitral. So, but for sure, it's not the case. It's not time yet to develop the tricuspid utility of the Pascal for transcatheter options in the tricuspid side. We're going to develop that through the next iteration of the meeting, but definitely this is something that is utilized. Pascal in the tricuspid position works, and I have to say that the Pascal ACE seems to be a kind of asset to when it remains visible, the central or anteroseptal tricuspid regurgitation, you get very good results with the ACE. So it's quite exciting. Do you have any comments that you would like to address, you guys attending the session? So it seems that we've covered quite a lot during this hour and a half. So trying to summarize, so what did we learn today? So I guess that all together, regardless of the amount of experience that we may have, we've learned how to better understand the key features of the Pascal device, the differences between both iterations. We have learned as well how to try to select and tailor the Pascal type to the anatomy of the patient. We all together also have learned how to try to achieve a good program, starting with the most appropriate cases and then gradually but quite swiftly moving to more complex cases in a way that is organized to make sure that you shorten your learning curve, gathering cases, learning from the experience of more experienced operators through a proctored phase. We have learned also that in terms of data, it's extremely reassuring that we can say, and quite honestly say, that there is equipoise between Pascal and the mitral clip for the vast majority of the patients, the ones who have a favorable anatomy, as we have described through the A2P2 case that Shinichi has demonstrated, or a little bit more complex cases, or even extremely more complex cases, based on the class 2D registry and the cases that we've seen from Sam. So the tricuspid we're going to see in the future. So I hope that you agreed on the conclusion that you are going to go back home with all these learnings. Exchange among yourselves, go to the ones, your Edwards representative, to learn more about the device. And all together, we should continue to exchange our experience, to share our experience, to try to understand how to position such and such device, such and such iteration based on the anatomy of the patient. So I pretty much enjoyed I a lot enjoyed the session. It was really fun to discuss with all of you guys. So thank you for helping us promoting and generating such an educational content. Thank you for you being there and attending the session and for the couple of questions that we had. And thank you for Edwards for supporting this symposium.